Hello and welcome to Pulmonology Read Aloud. Today we are going to be talking about a new guideline which has appeared in the European Respiratory Journal in 2024, the revised ISHAM ABPA Working Group Consensus Practice Guidelines. ABPA is a very important diagnosis and a very important differential in our asthma patients. And ever since the previous guidelines for ABPA were rolled out, there haven't been much changes to what we know in ABPA practice. So today I'm going to present to you this guideline paper and read it aloud for you. So let's get started. So, the consensus statement for ABPA that has been published in this paper is based on a Delphi consensus method in which several collaborators from India, from UK, and other countries, a multi center collaboration has occurred where the experts looked at certain common questions and gave their consensus. And when more than 70% of the consensus was met, when it was presented as a recommendation. So it's a heterogeneous group, but a group of specialists who've been dealing with allergic bronchopulmonary aspergillosis. And we know that ever since ABPA was first described in 1952, the cases of ABPA that are coming to notice are ever increasing. So let me just give you a brief overview of this group. So the ISHAM group is actually an international society for human and animal mycology. So it deals with fungal diseases. And this expert group has now given this consensus statement for classifying and treating not only allergic bronchopulmonary aspergillosis related to Aspergillus fumigatus, but also mycosis, ABPM. The first important recommendation that has come out of this consensus statement is that we must screen all our asthmatics for Aspergillus fumigatus sensitization. So there's a common belief that when we see an asthmatic who's not doing well, who is having certain complications, we start thinking about ABPA as a complication. But the statement really specifies that for all asthmatic adults, we must do a fungus specific IgE level to screen. For children, however, this may be applied only to children who have a difficult to treat asthma. But for adults, we should screen all asthmatics. Now, allergic bronchopulmonary mycosis is another term that has been specified in this guideline, and essentially it is an ABPA-like syndrome, but the fungal agent here is not Aspergillus fumigatus. So any other mold, any other fungus, even other species to Aspergillus fumigatus like flowers could be a cause for ABPM. So it presents usually like ABPA, but when you do the Aspergillus fumigatus IgE, that level comes out normal. So you usually think about other things because you feel that it's negative. But here, it's important to understand it could be other mycosis. But one very important point to be noted here is that you should be demonstrating some fungus in the sputum only to be giving this diagnosis. So a repeated fungal growth in the sputum is a part of it. So here when we look at ABPM, it's a more broad spectrum of fungal mycosis affecting the lung. What are the changes that have occurred in the ISHAM group statement ever since its last guideline in 2013? Now it's being emphasized that it's very important to identify and treat ABPA right away instead of working up a patient when you have any signs of bronchiectasis or worsening. So it's important now to start identifying it earlier. Secondly, a skin prick test, which was very commonly used to check for fungal sensitization, is considered inferior to doing a specific Ig level for Aspergillus fumigatus. So, a skin prick test may be done in situations where you do not have access to Aspergillus fumigatus IG testing, or you may want to do it as an easy method when your patient is sitting in your chamber, but it is inferior to doing a serum level. When you are doing serum levels, another thing that's important is to test for Aspergillus fumigatus specific IgG. And when you are doing that, it's better to perform an ELISA test, an enzyme immunoassay test. That is more superior to doing an immunoprecipitation test. So that is also something that has to be remembered. Also, there are newer assays that may be available, like the lateral flow assays, which can be utilized. And the authors have also placed a lot of emphasis on the diagnostic levels or the levels that would be considered for suspecting and treating ABPA. So, while earlier we would look for a serum total Ig count more than 1000, now it's encouraged to start thinking of ABPA when the diagnostic count is at least 500. So the serum total Ig levels should be 500 and above international units per ml when you are suspecting ABPA and not 1000. So this lower cutoff gives us a more sensitivity. So the recommendation is that in case you are not able to detect Aspergillus fumigatus specific sensitization, you must look for others. But at the first go, you must evaluate for Aspergillus fumigatus sensitization. And also, it's also important that if you have a difficult to treat asthma patient, but your A fumigator sensitization is negative, you could check for A flavus, you could check for Niger, and you could check for other fungi like Cladosporium, Mucor, so as to diagnose ABPM. The group does not recommend the periodicity of screening for affumigator sensitization. Say, should you check all your asthmatics annually or biannually? So they haven't been able to reach that consensus in case the test is negative initially. But definitely, if your patient is not doing well or is deteriorating or comes with increased symptoms, having been on treatment, this should be something that should definitely be on your mind. So, what tests should we do when a patient comes in with asthma and we want to check for ABPA? So, we must perform Aspergillus fumigatus specific IgE and IgG levels. We must perform serum total Ig levels, and we must also perform a peripheral blood eosinophil count. Now, what was practiced earlier was definitely looking at an absolute eosinophil count, and it was very high. We used to look at counts which were um, higher than 1000 and then also doing an Ig level and then finally going to Aspergillus specific testing. But now what's recommended is you can go ahead and do these tests. The serum total Ig here needs a mention because it's very non-specific. So if you only do the serum total Ig, you may miss out on ABPA cases. It's a non-specific marker of immunological activity. It has a very big differential. But when you do it as a follow-up for patients with ABPA, it tells us about disease activity. So it's a very good monitoring tool. So it's good to have a baseline total Ig level. And when you record this total Ig level as baseline, and now your patient is stable, you establish a new baseline. So the new total Ig level that the patient has on follow up is our new baseline. Hence, it is a very good tool for monitoring. In fact, for monitoring, there's no recommendation that mentions that you should be repeating Aspergillus specific IgE levels for monitoring. It's basically the total IgE that's recommended mostly. And whenever we see an increase in more than 50% of this new baseline serum total IgE, that is when we would say that this patient has an exacerbation. So there were earlier statements which used to mention even 25. So this guideline statement mentions 50% of increase from the earlier baseline as a sign of exacerbation. And regarding skin test, again, skin test is inferior. However, when there is no availability to diagnostic testing with immunoassays, it could still be used. What is the importance of doing blood eosinophils? Now, eosinophils still drive the major inflammation in ABPA because a lot many cases have asthma as well. So, eosinophil counts are also important in guiding therapy to us. And sometimes, if your patient has high eosinophils, you can actually initiate this patient also on biologics in case of a severe asthma, difficult to treat asthma, or recurrent ABP exacerbations. So, biologics have been used in ABPA also. There are several cases and case reports. The guidelines do not recommend it directly as a form of treatment. However, if your patient has very high eosinophils, that could be a form of treatment in advanced ABPA or in combination therapy. So the guideline group does recommend blood eosinophil counts to evaluate ABPA, and the cutoff here should be 500. So anything above 500 should also raise our suspicion. Now, when we are talking about ABPM, here an additional test, as I said, has to be sputum culture. So, sputum fungal cultures will be very important if you are giving a diagnosis of ABPM, and they're also important because they help us assess what will be the azole resistance. So, we ideally should be trying to get a sputum fungal culture done before starting antifungal treatment, and later on you can also use it to characterize a treatment failure. A lot of cases who undergo bronchoscopy and have a sputum fungal demonstration also can be measured again and reevaluated with sputum culture. Galactomannan is another test that we commonly use in diagnosing fungal diseases because it's a very vital component of the cell wall of Aspergillus. And if you are able to document galactomannan antigen, it does diagnose invasive pulmonary aspergillosis. But when you're talking about galactomannan and ABPA, the accuracy is not very strong. So it is recommended against in the use for diagnosing ABPA. However, a fungal culture can give us a lot of clue for ABPM as well. So, what are the consensus criteria? Let's revise. Number one, whenever you have any patient who has a predisposing condition like asthma or cystic fibrosis or COPD or bronchiectasis or a post TB patient, or anyone who has a compatible clinical history or a radiological presentation such as central bronchiectasis, here you would send Aspergillus fumigator specific IgE, which should be more than 0.35, and serum total Ig more than 500. There's also a strong mention that the Aspergillus fumigator specific Ig will vary with the manufacturer's kit, and in various countries there is a different cutoff. So we look at the cutoff according to the test being done, and the serum total Ig instead of 1000 should be 500 as a cutoff. Other components that the patient must have, along with the probable clinical history or radiology and these serological testing, is that he should have any two of these components, which include a positive IgG against Aspergillus fumigatus. That's why we send that right away, and a blood eosinophil count more than 500, or we could have had a history of a blood eosinophil count more than 500, or you have a CT chest consistent with ABPA bronchiectasis, mucus plugging, and HAM, which is high attenuation mucus, or fleeting opacities on the X-ray. So, in a nutshell, you should have a clinical radiological picture along with positive specific IgE and total IgE, and any two of a positive IgG or an eosinophil count being high, or a CT image. Also, whenever his patient gives a history of expectorating mucus plugs, or you see a finger in glove appearance, or you see fleeting opacities on the chest x ray, or you see a homogeneous opacity which is not explainable, again, this could be a compatible clinical presentation. For a patient whom you do a skin test, that is also acceptable in case you don't have IgE. And even if your total Ig count is less than 500, but the rest of the criteria are being fulfilled, that can be taken as ABP, especially in patients who've taken steroids frequently. Regarding Aspergillus specific IgG, the cutoffs for Aspergillus specific IgG keep changing from country to country, region to region, and manufacturer. So you use the manufacturer's recommendations, but there should be more studies in future to establish cutoffs in specific populations. And ham or high attenuation mucus is pathognomonic for ABPA. So when you see that on a CT scan, it confirms ABPA diagnosis even if any other criteria is not fulfilled. So that's very important. And in recent innovation has been newer specific IGs against our ASP F1, F2, and F4. So specific components of Aspergillus which could be used for supporting the diagnosis. Now, when we talk about ABPM, how things changes, you still want a predisposing condition and presentation. You still want fungal specific IgE and total Ig to be high, but you would want two sputum or one bowel fluid fungal culture growing the causative fungus. So repeated isolation of fungus is very important to diagnose ABPM. And here, this specific Aspergillus fumigatus Ig, maybe instead of that, you could have something specific to Aspergillus flavus or other fungus, which could also reflect that it is ABPM. So this is a very good flow chart which is mentioned in this guideline statement, which mentions that whenever you have predisposing factors and specific Ig more than 0.35, we are looking for total Ig, eosinophil count, HRCT, no bronchiectasis, we call it ABPA-S. Bronchiectasis, we call it ABPA-B. Mucus plugs, the new classification mentions ABPA-MP, HAM, ABPA-HAM, and cystic fibrosis, ABPA-CPF. So these are the new types of classification of ABPA subtypes. If the total Ig is not high, but you have a repeated isolation of a non-Aspergillus species, a sensitization to the implicated fungus, a high total IgE with high eosinophil count, fleeting opacities, or CT chest, which is compatible, then this is ABPM. Coming to the indications of doing a bronchoscopy in ABPA, when we have so many serological tests, fungal sputum tests, and others to give us a positive diagnosis, sometimes we may still need to perform bronchoscopy, which would be mainly when you have an uncertain diagnosis or where you're suspecting ABPM, but your sputum cultures are not informative, then you can send a bowel fluid sample for fungal culture. Patients where you are suspecting ABPM or they have ABPA and they have an unexplained hemoptysis, or patients where you suspect a chronic infection, such as you are suspecting a co-infection with TB or non-tubercular mycobacteria, and before you start giving steroids for ABPA, you would want to rule out this active infection, then a bronchoscopy should be indicated. In fact, sometimes very infrequently though, some patients may require a therapeutic bronchoscopy to remove the mucus plugs in case they come with respiratory failure or recalcitrant mucus plugs causing hypoxemia and clinical worsening despite systemic therapy. What are the comorbid conditions where you must think about ruling out ABPA, specifically COPD, TB or old TB, bronchiectasis, and severe asthma patients? Now, talking about severe asthma patients, there is a term which is asthma with sensitization to fungus. So when your patients with severe asthma, they may be sensitized to Aspergillus fumigatus or other fungi, and they may have just a raised total Ig count. Then you will call them as severe asthma with fungal sensitization, and this will all come under the umbrella of fungal asthma when they do not fulfill the specific criteria for ABPA or ABPM. Also, we must rule out other immunodeficiencies, ciliary disorders, and definitely active mycobacterial infections. This is the recommendation for clinical classification and treatment as we used to have earlier, where we would call acute ABPA, remission and exacerbation, treatment dependent ABPA, So this has now been divided into these five classes: acute ABPA, response, remission, treatment dependent ABPA, and advanced ABPA. So the numbered stages have been removed, like stage 1, 2, 3, 4, because that really does not reflect the change in severity. So no numbering, but five categories: acute, response, remission, treatment dependent, and advanced. Again, remission basically is diagnosed just like in asthma when patient is not having exacerbations, is not steroid dependent. So that is the best possible stage. But when you talk about acute ABPA, this patient may be newly diagnosed, so undiagnosed previously but now meeting the new criteria, or acute ABPA exacerbation when a patient is a known case but he has a sustained clinical worsening more than 14 days, or radiological worsening, increase in IgE by 50%, along with you've ruled out other causes. In an asthma exacerbation, which needs to be differentiated from an ABPA exacerbation, you will still get worsening symptoms for at least 48 hours, but you may not see a rise in IgE total, you may not see a radiological deterioration, and that may not be associated with an increase in IgE by more than 50%. In case we are actually dealing with an infective exacerbation and not an ABP exacerbation, again you will get a clinical deterioration along with cough, breathlessness, and change in sputum volume, but you will not get any immunological changes. So, this is how you can differentiate. A patient with response will have a good symptomatic treatment improvement by at least 50% on a visual analog scale or a Likert like scale after 8 weeks. So, we'll be coming to that. He should have a radiological improvement or more than 50% reduction in the opacities, or he should have a decline in serum total IgE by 20% after 8 weeks of treatment. So, I repeat, when you call a patient to have a good response, there should be a symptomatic improvement of more than 50% and one of the two, either an improvement of radiology by 50% or a decline in serum IgE by 20% after 8 weeks. A patient in remission would be the one who has a sustained improvement for more than 6 months. He is off steroids now, and there is no increase in IgE by more than 50% from his new baseline. If your patient is on biologicals or if your patient is on long term antifungal, he can also be called as being on remission if they are meeting this criteria. For treatment dependent ABPA, we need to continue treatment to ensure that he has no exacerbations. So, he should have two or more consecutive ABPA or ABPM exacerbations within 3 months of stopping glucocorticoids. So, you stop steroids, and within 3 months, it has happened two or more times that he repeatedly has an exacerbation. That's treatment dependent, and he should have a worsening of respiratory symptoms and imaging or rise in IgE by 50% within a month of tapering the steroids on two occasions. So, two times it should have happened that this patient you tried to taper steroids, and within a month, this patient landed up getting a worsening of imaging or symptoms, then he is treatment dependent. Coming to the fifth category of advanced ABPA, this patient will have extensive bronchiectasis. So, more than 10 bronchopulmonary segments will be involved due to ABPA or M on imaging, and he should have signs of associated pulmonary hypertension or cor pulmonale, or a further complication of chronic type 2 failure. So, advanced ABPA is one who has extensive bronchiectasis and he has cor pulmonale or type 2 failure. So, this is the five categories of ABPA according to the new 2024 statement. Also, we used to have a classification of ABPA S, B, MP, HAM, and CPF, which is radiological. So, the radiological classification remains as ABPS, where there is no bronchiectasis, ABPA B, where there is radiological bronchiectasis, ABPA MP, where you see mucus plugging, but no ham, no high attenuation mucus, and bronchiectasis and mucus plugging both are there, or ABPA with ham, where you have a high attenuation mucus, ABPA with CPF, chronic pleuropulmonary fibrosis. This can happen in advanced ABPA, this can happen in cystic fibrosis patients also. So, chronic pleuropulmonary fibrosis, ABPA with two or more of the following, which includes pulmonary fibrosis, which includes fibrocavitary lesions, a fungal ball, and pleural thickening. So ABPA CPF with two or more, either pulmonary fibrosis, fibrocavitary lesions, fungal ball, pleural thickening. So this is how we define the radiological classification in ABPA. Sometimes you can see other findings like a consolidation, like tree in bud appearance, like atelectasis, which can be seen in any of these classifications. So now coming to the treatment. So the treatment is basically targeted to control the patient's immune response and to reduce the symptoms. So the target is that we use anti-inflammatory agents, which may be steroids, antifungals, azoles, sometimes biologicals targeting type 2 immune response to control the immune response. And the fungal agents will reduce the colonization as well. The goal is to give the patient symptom relief, to improve the control in asthma, to prevent the asthma exacerbations and ABPA exacerbations, and to prevent bronchiectasis from progressing. And there should be minimal adverse events related to the therapy. So, how do you manage acute ABPA? Glucocorticoids are the most effective treatment for acute ABPA. The treatment duration is usually for 3 to 5 months, on an average 4 months. We start with a low to moderate dose of oral prednisolone, which is 0.5 milligram per kg per day, initially for 2 to 4 weeks and gradually tapered. There are different kinds of options of protocols for steroids, which we'll be talking about. Also, you need to closely monitor your patient by regular clinical review, X-ray and IgE, preferably in 8 weeks or every 3 to 6 months to require any decision making for escalation or de-escalation of treatment. Again, if you have an asymptomatic ABPA without much changes of the CT scan, you may actually just closely observe that patient immunologically and clinically. Oral antifungal triazole, especially itraconazole and even voriconazole, they have very good effects just like steroids, but here the trajectory to improvement or the clinical improvement is slightly slower, but the safety profile is better. Oral itraconazole for 4 months, either alone or in combination therapy, is a good alternative. And as an initial therapy for acute ABPA, it can also be employed. Now, voriconazole is also being used extensively in ABPA, and it has similar efficacy as glucocorticoids for treating ABPA, but there are certain concerns with its use as first-line therapy because patients usually do not tolerate voriconazole so easily, and there are also cost-related issues. Secondly, prednisolone can also decrease the plasma concentration of voriconazole in a dose-dependent fashion. So whenever we are starting a combination therapy, we would prefer not to start it with voriconazole because its concentration may actually be suboptimal. When we're talking about glucocorticoids, again, methylprednisolone is commonly used instead of prednisolone, but it's very important to take care when you are using it along with oral itraconazole because there is a higher risk of Cushing syndrome and adrenal insufficiency when you use methylprednisolone with oral itraconazole. And importantly, as we all know, a combination of inhaled steroids, so inhaled budesonide, inhaled fluticasone, they can be used as a steroid sparing agent. But when you're using this in combination with itraconazole to the patient, that can also cause exogenous Cushing syndrome and has to be kept in mind. In fact, there have been recent RCTs up to 190 patients mentioned in the consensus statement that has found no significant reduction in ABP exacerbations when you combine prednisolone and itraconazole compared to prednisolone alone. In fact, you may have higher adverse events. But when your patients have a very high blood eosinophil count, extensive bronchiectasis, they have recurrent exacerbations, a combination therapy can reduce the exacerbation rate. Looking for other oral azoles, posaconazole, isavuconazole, and newer azoles have also been tried for ABPA, but there is very poor or little evidence for them as of now. When we talk about biologics, it's important to mention here that this consensus statement clearly mentions that there is no data to support biologics as the first line agents in ABPA and should not be resorted to. Adjunctive vitamin D supplementation can be given if your patient is on glucocorticoids, but it will not help in managing ABPA. The vitamin deficiency otherwise should be corrected in long term glucocorticoid use. And when you give inhaled corticosteroids, a high dose of inhaled corticosteroid will not achieve the immunological control or reduce exacerbation as a sole therapy. So, oral steroids still remain as the mainstay of treatment. Coming to the treatment of ABPA based on the level of evidence, let's revise. So, a high dose inhaled steroid will not achieve symptom control or reduce exacerbation. Level 2 evidence. Oral steroids are most rapidly acting treatment. Level 1. Oral itraconazole, voriconazole have similar efficacy. Level 2. Oral itraconazole has steroid sparing action. Level 2. Oral posaconazole has also been studied, but level 3 evidence it can achieve clinical remission if the patient is intolerant to other azoles. Amongst the biologics, omalizumab has been the most studied and given. It does reduce asthma exacerbation, has some steroid sparing effect, level 2 evidence. But other biologics, mepolizumab, benralizumab, dupilumab, tezepelumab, also reduce asthma exacerbations and have steroid sparing action, but there is level 3 evidence. And nebulized amphotericin B has been used in certain studies to reduce the number of ABPA exacerbations when used as a maintenance in stable ABPA, a level 2 evidence of the same. Coming to management of ABPA exacerbations now, we already defined it as an increase of symptoms to more than 50%. Almost 50% of patients with ABPA will experience exacerbation despite treatment. A sustained clinical worsening more than 14 days with symptoms with new infiltrates on chest imaging and increase in IG more than 50% above the baseline. And you need to distinguish them from asthma exacerbations and infective exacerbations. These are the various drugs which we use for treating allergic bronchopulmonary aspergillosis and mycosis. Talking about prednisolone first, we'll be talking about the dose regimens. We all know the adverse effects and they have to be strongly monitored. Methylprednisolone, as I mentioned, is also used as an alternative, but you have to be more careful when you're using it in combination with itraconazole. The dose is zero point 0.4, zero point 0.2, and zero point 0.1 milligram per kg per day each for 4 weeks and then tapered by 4 milligram per week to complete a 4 months treatment. You have to look at side effects just like prednisolone and be more wary with itraconazole because it will increase the plasma levels of methylprednisolone but not prednisolone. Coming to deflazacort, which is also used commonly, the dose here would be 0.75 milligram per kg per day for 4 weeks, decreased by half every 4 weeks for 2 months, and tapered by 6 milligram every 2 weeks till 4 months. Here, it has lesser metabolic side effects. There are new trials ongoing, especially one comparing prednisolone with deflazacort at the time of writing of that consensus statement. Antifungal agents that are conventional and super bioavailable. So, super bioavailable is a novel itraconazole that is now available, which has a targeted release of itraconazole in the small intestine. So, the serum levels are more predictable, the inter-individual variability is less. So, it's a potentially useful drug. It's also available now in our country. So, there could be a conventional capsule, which will be 200 milligram twice a day, making it a total of 400 milligram for 4 months or 16 weeks. You can go as high as 600 milligram. Always give it with meals to improve absorption. Side effects, commonly I've noted pedal edema as one of the side effects, but it can also cause gastritis and nausea and hypertension. And the recommendations say that you must do therapeutic drug monitoring of itraconazole. Trough levels should be more than 0.5 milligram per liter. There is this super bioavailable capsule, as I mentioned. It comes as 130 milligram capsule, given total dose 260, so 130 BD for 4 months. Maximum can go high as 390, but this one has to be given on an empty stomach. Said to have better side effect profile, um, as it is predictable and it is also released in the small intestine. And the other things that have to be taken care of is that PPIs and antacids should not be given along with it. Voriconazole is the next 400 milligram per day, two divided doses, maximum 600. It should also be given on an empty stomach. And it does have similar side effect profile but needs therapeutic drug monitoring. Posaconazole in form of delayed release tablet or isovuconazole are also available now, and nebulized amphotericin B and liposomal amphotericin B has some role but not commonly used. Amongst biologics, omalizumab, mepoli, benrali, dupuli, and tezepelumab all have been used, and dose is based on body weight and omalizumab, not on the others. Let's quickly come to an example. So if you're giving prednisolone to a 60 kg patient, then the dose can be in two ways. One, you can have 0.5 milligram per kg, so 30 milligram per day for 2 weeks. Then you make the same dose for alternate days for the rest of the 8 weeks. Then you reduce it by half, so 15 milligram a day for 2 more weeks, and then you start reducing 5 milligram per 2 weeks till a total of 3 to 5 months. Or instead of making the same dose alternate day and switching it after 8 weeks, you could just start with the 0.5 milligram per kg per day, which is 30 milligram for this patient for a month, then reduce it to half for another month, then another half for another month, and then 2.5 milligram for this patient, which is reduction of 5 milligram till the time of discontinuation. Coming to monitoring now. So whenever you see a patient who's on treatment, the first follow-up should be within the first 8 weeks. And this follow-up should have monitoring for clinical symptoms, the total IgE level, and the X-ray. So symptom monitoring is important by using certain scale, such as a Likert scale, which would patient would say that he does not have any improvement, or a mild improvement if it's less than 25% improvement, a moderate 25 to 50, and a significant improvement would be more than 50% of the baseline. Patient also goes and does the IG, and as we mentioned, a change in IG levels by 20% is good improvement. Significant improvement in symptoms, significant improvement in imaging, and 20% reduction in IgE would categorize as a good response to treatment. So, you can use spirometry also for monitoring patients. Serum aspergillus specific IgE and IgG do not consistently fall on treatment, so may not be repeated. Blood eosinophil counts may be used for patients with worsening to assess for future directions, but they have no role in routine follow-up. So are those for specific Aspergillus antigens till date. There are not enough studies. Therapeutic drug monitoring is indicated for itraconazole or other oral azoles at 2 weeks and then 3 months or during stages of clinical worsening. And we have to keep in mind that the minimum therapeutic levels we're looking for itraconazole should be over zero point 0.5, for voriconazole more than 1, and posaconazole more than 1 as well. And since the patient is on steroids, you would want to see his plasma glucose, his blood sugar, body weight, mental status, and liver function when your patient is on oral azoles. Now, a few words about certain specific situations. One is when your patient is treatment dependent ABPA. Almost 10 to 25% of patients will become treatment dependent, and you will not be able to take them off the steroids or the antifungals. Here, there are trials for long-term itraconazole, even up to 8 months in exacerbations or patients which are treatment dependent and can be tried. Biological agents are also an option, and there are small case series and case reports where stable treatment dependent ABPA patients are given biological agents, of which omalizumab has been extensively studied, but there are also studies with mepolizumab, benralizumab, dupilumab, and tezepelumab. Coming to ABPA in remission, we want to make sure that the patient's underlying asthma and bronchiectasis is managed with clinical review, with the immunological tests and lung function tests, 3 to for 3 to 6 months for the first year. So every time, every 3 months or 6 months in the first year, the patient should be coming to your clinic, and then you can do it 6 to 12 monthly interval. For patients who require prolonged remission, sometimes long-term itraconazole or biologics or nebulized amphotericin B have to be started in certain special cases. The last of the 5 categories is advanced ABPA or extensive bronchiectasis. Here, nebulized hypertonic saline, nebulized antibiotics, long-term azithromycin therapy, and LTOT have been done. Also, these patients need to be vaccinated. The aim here is to reduce the symptoms. So, nebulized hypertonic saline will reduce the sputum viscosity, ease the expectoration of mucus plugs, and we must remember that it should always be preceded by nebulizing with salbutamol because there may be a chance of bronchospasm. So this is something that may have to be done in advanced ABPA patients. But nebulized antibiotics, long-term azithromycin, they can improve outcomes in patients with infective exacerbations. Just the word of caution is to make sure that you check the ECG because it can cause QTC prolongation. And for patients with type 2 respiratory failure, they may have to be on LTOT, they may have to be on an IV, and patients with ABPA or bronchiectasis must be vaccinated, especially for influenza and pneumococcal vaccines. But patients who have chronic and allergic aspergillosis respond poorly to the 23-valent pneumococcal polysaccharide vaccine compared to healthy adults. So, either you give them the vaccine before starting steroid therapy, or preferably delay it until their condition is better controlled. After you've given them antifungal steroids and their allergic asthma, ABPA is under control. So that's something which is very important to note. Some mention about pregnancy in the guidelines. Oral steroids are safe in pregnancy for ABPA. Oral itraconazole has more risk of premature births and abortions, and biologicals should not be used during pregnancy. For children, systemic steroids can cause growth retardation and they have an erratic bioavailability. However, they are the prime treatment modality. There are not much trials on treatment of ABP in children. Mostly glucocorticoids are used. Their oral itraconazole therapy is also recommended in children, sometimes as the first or sole therapy, or systemic glucocorticoids alone can be given. When you are looking at biologics, omalizumab and mepolizumab for asthma is approved in children above 6 years of age. It's important to tell the patient that environmental control is very important because ABPA will increase during humidity, dampness. It will increase when the ventilation and heating is not appropriate, and in spaces which require regular cleaning because the spores could be building. So it's important to maintain a good indoor air quality, and that has to be told to the patients. This is all from me for the revised ISHAM consensus practice guidelines for ABPA. I hope you benefited with it. Do subscribe and follow me for future more guidelines and everything in pulmonology. Thank you.